Hello, I'm going to now talk about the optimal use of NRTTI plus non-nuc regimens in routine clinical practice. Here are my disclosures, and now I'd like to sort of set out an agenda. Now, of course, because these aren't licensed yet, this is all theoretical and my own personal view, but I'm going to cover R to start with a 2-drug regimen, R to switch really mainly to avoid or because of side effects. And then I'm going to talk a little bit about drug interactions and tuberculosis and the oral contraceptive pill, a little on pregnancy and HIV too. But really the limits to what I'm going to say about these last two subjects, pregnancy and HIV too, is that we have no data on pregnancy, and all we know is that islatravir works for HIV too, but doravirine, which is the other component of this, has no effect. So what's the real advantage of being a 2-drug regimen? Well, there have been increasing concern about other nucleoside toxicities. We had the abacavir story and the tenofovir DF story, which has now been mitigated by the development of TAF, and also about the fact that if you're a 2DR and don't have a boosted agent, it limits drug-drug interactions. Obviously, cost is an issue. Having 2 drugs should cost less than having 3, but that's not perhaps always the case. And we don't know what the cost of any combination of an NRTTI and a non-nuc will be. Fewer drugs obviously may be a good thing, especially in the long term when people are on drugs for 40 years. And you know, we have this issue now with a lot of our cohort being aging, with multimorbidities, with polypharmacy. So perhaps having less drugs is a good thing, not only in terms of being able to take pills, but also because of the drug interactions. Now, there are some limitations. So one is, and especially with the proposed NRTTI and non-nuc combination of islatravir and doravirine, would be about hepatitis B co-infection. You'd have to screen for this first because of the inactivity of that combination against hepatitis B. We don't know about toxicities with new combinations that haven't been discovered yet, and we've seen this with lots of drugs in the past, that it can take several years before new things are thought about. We've seen the weight gain with dolutegravir and TAF and other issues with drugs that have taken a while for us to realize. The other thing is the access to resistance testing. If you're going to do a rapid start with this drug combination, is it safe to give the combination and get the resistance test later, or not to do a resistance test at all? Globally, interactions with TB treatment is very important, especially with the rifamycins, and other drug interactions, and I'm going to talk about this with the oral contraceptive pill, are also important. Pregnancy, where we have no data, and that's very important to have studies whereby we can see whether or not this is safe in pregnancy, and also whether or not it's efficacious. Some drug levels of drugs go down in the 3rd trimester in pregnancy, and there are others that are much more preferred because of their PK profile. We do have an issue though with high viral load and low CD4 with dual 2-drug therapies, and we really need to make sure that if we're going to start these therapies in patients with a very high viral load and a low CD4, that they will be efficacious. And most of these drugs really haven't been studied in patients with more than 500,000 copies in detail. Now, one advantage, of course, of having this combination is that it could be an oral fixed dose combination, which has been used in trials. At the moment, we've got 2 drug single tablet regimens of dolutegravir 3TC and dolutegravir rilpivirine. All these others around the slide here are 3-drug regimens, but you can see that we might be able to have an islatravir doravirine, NRTTI and NNRTI combination, which again would be very useful for patients to be able to take 1 pill once a day. Now, let's talk about starting therapy with this regimen. So there are 2 ways to start. One is immediate start, and the world is moving towards, you've got a diagnosis, and almost on the same day or within a few days, you start antiretroviral therapy, and there's gathering data that increases retention in care and has better outcomes. But what would happen if you don't have a baseline resistance test or even a viral load or CD4 at baseline? How useful would this combination be in those situations? So the concerns would be you have some transmitted resistance to non-nucleosides or even to the islatravir, and the combination wouldn't be effective. Also, if you started with a high viral load and a low CD4, would this work? So in the immediate start scenario, I think we need a lot more data before we can actually say that we would start immediately with a combination like this. Now, what about a planned start? And many patients in the world, it's planned. You're diagnosed, we're going to get your blood test back, and then we're going to put you on the optimal therapy. But the concerns then would be if you had a high viral load and low CD4, even if you had a wild type virus, would this be effective? Well, we don't have much data, but I just wanted to talk about the naive data on islatravir plus doravirine. And this is quite a complicated a story in terms of a trial, but it's very logical. They started with 3 drugs of islatravir and doravirine, but they added 3TC. So it's a 3-drug combination. And as a standard, they had the comparator as doravirine, 3TC, and TDF. And then at week 24, they moved, if patients were undetectable, so this is an induction maintenance more than just a pure naive, they moved to a 2-drug regimen of islatravir, doravirine. And there are 3 of these here, all of different doses. So this is then saying which dose should we choose ongoing. And again, they kept a comparator arm. Well, the results were pretty good with, as you can see, various rates of success. Interestingly, this largest dose of islatravir had the less number of percentage developing undetectability through week 48. And in fact, the dose they've gone for is a 0.75. But if we look at this, let's look at some of the patients that had virological failure. Now, the first thing to say is, if you look, here's patient 1, and we can see the baseline CD4 count. And then as we move along here, you can see the viral load. And by week 16, you can see this patient became undetectable, but out at week 48 had a blip at 51 and a confirmed blip at 79. So is this actually a blip, or is this early virological failure? And you can see this along all of these patients. Now, one of the patients actually changed here. This patient changed before, this patient here changed before they reached week 40, where they had the 103, it went up, and before week 48, where it went to 93, and you can see the confirmed was just at 50 copies. So this patient actually switched therapy. These ones with the yellows were on the original randomized therapy after 24 weeks. Now, the interesting thing to note is that all of these viral loads are extremely low. That's the first thing. They're all in what we might think of as a blipping range. And then the second thing to say is that some of these had high viral loads at baseline. You can see 153, 626, and 437. So some of these had quite high viral loads, which is an interesting concept because I just want to come to this in the next slide. And 3 of the 6 patients who then switched to a new regimen still had low level viremia 42 days after the switch. And again, this comes to the fact that this could be a physiological phenomenon rather than a failure of the drug. And nobody met a criteria to get any resistance testing out of here because they needed to have more than 400 copies. So why did these patients, and some of them, as I've shown you, have high viral load, develop the criteria for virological failure? Well, first of all, did they fail? So they just developed a high viral load, and but interestingly, we would have had to follow them on for a long period of time, and that wouldn't have been ethical, so they had to switch. Was it just a blip? We know that about 4% of all viral loads are blips, and they're often low level. But what you can say is on the confirmation viral load tests, they didn't appear to be blips. They appeared to be true because the confirmation were all higher. Or could this be just virus coming out of the reservoir? And we've seen this in patients who have high viral loads, that they can have this low level viremia, or they can just dip below detectable and come up again for a long period of time. So I think we need to know that. But as I say, if we really want to know whether this combination works in high viral load, we need to have a phase 3 study where those patients are allowed to be included. The CD4 question, low CD4, wasn't answered because you can see down here that the CD4s were actually all over 200. So that's in the naive, although the data's from induction maintenance. What about using a combination like this in switch because of side effects? Now, what are the side effects of the day? And it's weight gain. That's the real important side effect that everybody's been concerning themselves with. Obviously, CNS side effects are always important, and we had those with the efavirenz, and then we had insomnia with the dolutegravir and the integrase inhibitors. But this weight gain with integrase inhibitors and tenofovir alafenamide, TAF, has been a concern. We've also always concerned about lipid abnormalities, and the other reason for switching is people with treatment experience who don't have any resistance but want to simplify their therapy. So let's have a look at the adverse events through week 48. In the study that I've just shown you, the induction maintenance, it's not a switch study to show you the adverse events, but it's at least something that you might look out for. And in fact, they were very, very similar in terms of serious adverse event rates. A few more with the triple therapy compared with the double therapy arm. And but as you know, they started off with triple, then went to double. But the most important one here was probably headache and diarrhea. But if you then look at the dose that they want to use, the 0.75, the headache compared with the 3-drug regimen and the diarrhea compared with the 3-drug regimen were very similar. And most of these events were mild, transient, and not thought actually to be related to the drug. They did see some elevated creatinine kinase, but no dose-related trends, and most of them were associated with physical exertion and all resolved. And I remember from the early integrase days, we saw some of this, and again, it was probably the same thing, that people cycled to the clinic or ran or did some physical exertion, and then it was seen in the adverse events. So nothing really very different to the doravirine 3TC TDF combination in triple therapy with the double therapy. Now, what about some metabolic changes? Well, you can see here, and if you look at this this color here, the change in the glucose from baseline, it's very small. This 3.4 is in milligrams per deciliter, and if you think that that's about 0.1. So it's very, very little in millimoles per liter. That's very, very little change at all. And you can see the doravirine 3TC TDF was slightly down, but the confidence intervals were wide. And if you look at the HDL to cholesterol ratio, the total cholesterol to the HDL ratio, you can see there's very little change. This is mean change. It's 0.2, 0.3. It's basically, it goes down a little, but very little indeed, in fact. Now, what about the weight gain? Well, in the way they measured the weight gain here was more than 5% from baseline. And it's a fair way of doing it because you want to see whether a lot of people gain weight. And you can see from some of the data here that 16% at week 24 for the triple versus the dose they're going to use was more at 40% here. Week 48, 36 versus 22.6. So this could be a signal that there's more weight gain with islatravir, doravirine compared with the triple arm, or it may be some effect of TDF, which of course does not have the same effect as TAF on weight gain from, say, the advanced study. So it's very interesting that it may be an effect of TDF here, keeping the weight down compared with there. Now, the weight gain, as I said, there's current concern with integrase and TF. And what about this? And I want to come into a little bit more detail about the islatravir data, but let's just go to this slide here. Now, these are changes in BMI over time with HIV positive versus HIV negative. And they followed a lot of HIV patients from the Kaiser Permanente cohort over many years. You can see 12 years of follow-up here. And if you look at the HIV negative, they just followed this group up and they gained on average 0.06 kilograms per meter squared per year. So it went from 28.7 to 29.4 as, in terms of their mean BMI. When you look at the HIV negatives who start, HIV positives, sorry, HIV positives who started on treatment here, you can see they went from 25.8 to 28.4. And one of the theories here is basically that this BMI increase in the HIV positives on treatment was a return to health. Though you can see this graph is still going up, and this one is slightly going up, and it'd be very interesting if they can follow this cohort a little bit longer. So perhaps starting antivirals makes you put weight gain on because you're returning to health. Now, as I said, I wanted to just revisit this, the weight gain on the doravirine islatravir study, and here you can see here's no change in weight, and here's the sort of scatter at 0 weeks, at 12, at 24, and at 48 of the various different doses of islatravir. And you can see they're really all grouped. There are a few outliers here, and I've already discussed that's the average change. But when you look at this, there really is very, very little difference between them in terms of groupings. Again, it's small numbers of patients. And I think really that we need much bigger studies. And it was interesting that most of this weight gain, and it's true, if you look at this graph and you look at this scatter part here, they're very, very similar, that most of it occurred between 0 and 24. And that's why they think it may reflect a return to health phenomenon. But time will tell. We need to see the trials and we need to see how this pans out. Now, what about using this combination in people with treatment experience and resistance? Now, if you're treatment experienced and you've had a lot of problem with side effects and you're on a complex regimen, you can see that you may be able to switch to this. But what happens if you have treatment experience plus resistance? Well, this is interesting. This is doravirine data that was presented at the AIDS 2020 conference, and they looked at all of these mutations. Now, it's well known that doravirine is effective against K103N, but they also looked at these other mutations that might have some significance with doravirine, these different mutations and even combinations. And actually, if you look here, the fold change was relatively low, all stayed below 5. This Y181C and K103M went just above 3. And here's the interquartile range. And I suppose the discussion here is, if you have an interquartile range that goes above, say, 3 or 4 or reaches 5, how confident are you that the drug's going to work? And then they looked at this various different NNRTIs here, and for example, that if you're susceptible to doravirine, very few people are, susceptible, would also be able to use a travirine. But if you look at doravirine here, if you're on a travirine and susceptible, you can see the cross reaction with doravirine. So this was very interesting in table, in that only 17% of people who doravirine would work would actually be susceptible to ephedrine. So doravirine does have a very good resistance profile, and I think this data is reassuring in terms that if you see these other mutations, then you will have some effect. Now, islatravir resistance is something different. There's been only emergence of resistance to islatravir in selected experiments, and what you can see is the M184 either I or V, and it's causes 3.9 or 5-time fold reduced susceptibility compared with wild type. But what the manufacturers have said is that the concentration you get of islatravir at the clinical dose that we're going to expect should suppress these mutations. It should stop them from either occurring, or if you've got them, be able to overcome these. You can see here from another table I've shown it's effective against the K65R, which is very useful. EFDA was the old name for islatravir. So but we have to wait and see. I mean, a study needs to be done in people with the 184I or V, with the K65R, etc., to ensure that this double combination is effective, because what we don't want to do is to generally use a combination in patients who have got background mutations and then find that we're giving effective monotherapy. Now I want to move on to another subject, which is for WHO, for their guidelines, is critically important, is could this combination be used in tuberculosis? Now, you can use these drugs with rifabutin, and so in countries where rifabutin is available and we can treat TB with rifabutin, that's absolutely fine. And doravirine can be used as 100 milligrams BD with rifabutin. There was a poster at AIDS 2020 outlining this, but you can't use doravirine with rifampicin or with rifapentine. Rifapentine is becoming a drug now of the future for prophylaxis. So doravirine can be used with that, and islatravir doesn't interact with cytochrome P450 enzymes, and so it should be able to be used with rifabutin or rifampin. So a combination of doravirine, islatravir, with rifabutin being used in tuberculosis is a potential yes. But most of the world uses rifampin or rifampicin, and therefore it's going to be difficult to use that combination in that situation in most countries in the world. The oral contraception is important, and there's been a study where doravirine, there's no significant interaction, and levonorgestrel and ethinyl estradiol were not effective. So again, for women who are on contraceptives, it appears to be a good combination to be able to give them without concerns that the drug levels of the contraceptives are going to be affected. So we've gone through quite a lot of different ways that we might be able to use this drug, but as I say, we need the answers from clinical trials. So this is the so-called Illuminate Clinical Development Program for the NRTTIs and non-NUCs, the doravirine islatravir study. And you can see here the dose, 100 milligram with 0.75. And we're going to look at data, hopefully, that will come out of a double-blind, heavily treatment-experienced program of 2 virologically suppressed, one with open label and one with double blind against Biktarvy, bictegravir, FTC, and tenofovir alafenamide. So that will be very interesting. I always like to see double blind studies being performed. And then you can see a big treatment naive study against bictegravir, FTC, and TAF, again, double blinded. And then there will be a single arm study looking at this in either treatment naive or virologically suppressed adolescents. And again, a drug with very few side effects, which has few drug interactions, which is easy to take, might be of benefit to that particular group. I will just add one other thing, is that they're aiming in this to recruit a large percentages of women into the studies, which is very important because, as you know, the history of HIV in drug development has underrepresented women quite greatly. So this will be important that, this is followed through. So in conclusions, potential use. Yes, a 2-drug fixed dose combination will be very welcome. As I say, we've got 2 at the moment. This will be a 3rd. The side effect profile looks good, but we need more data. In terms of switching, we need to know more about the weight gain. It appeared that there was, the numbers were a little larger in the dual therapy compared with the triple therapy, but this may have all been a return to health by week 24. Lipids look pretty neutral, as well as does the glucose. We've had no signal about CNS side effects. And in treatment experienced patients with resistance, that is really the study we need to know, whether the doravirine polymorphism, in reverse transcriptase, and whether the 184V is going to affect this. We now have seen drug interaction data in tuberculosis, and that rifabutin could be used, not rifampicin. We've seen the data on the oral contraceptive pill. Pregnancy, well, that's going to take a while to come. But we hope that they'll try and gather this data as soon as possible. And the last thing, HIV-2, islatravir is effective, but doravirine isn't. So islatravir as a single agent with other agents like boosted PIs or integrase inhibitors will be useful, but as a doravirine, islatravir would not be. So the future is very interesting for this combination of a new nucleoside analog. And I think in the next 2 to 3 years, we're going to be able to look back at and look at all the data and know exactly where to use this in routine clinical practice. Thank you.